So we'll be discussing about hypertensive disorder in pregnancy. So it's a in this class we'll be discussing about terminology and classification, risk factors, etiology, pathophysiology, prediction and prevention, and the management. But तिम्रो रेस्पोन्स गर्दै गर है, सुनेछ कि छैन थाहा हुँदैन. सचिन एकजनाको माइक अन गर्दा पनि हुन्छ. सचिन
हजुर सर
एकजनाको माइक अन गर. सचिनको अन गर न, म्युट नराख. सुनिरहेछ?
हजुर सर सुनिरहेछ सर.
So hypertension in pregnancy is defined as a rise of blood pressure of systolic more than 140 and diastolic more than 90 millimeter of mercury, which are recorded on 2 occasions, 4 hours apart, after 20 weeks of gestation. Right? त्यसमा दुई तीनवटा क्राइटेरिया के भयो त? ब्लड प्रेसर क्राइटेरिया भयो एउटा. Blood pressure should be more than 140/90, which are recorded on 2 occasions after 20 weeks of gestation. That means those patients who are previously normotensive छ भने उनीहरुको blood pressure चाहिँ 140/90 भयो भने चाहिँ we label them as a case of hypertensive disorder in pregnancy. This means like before normotensive भयो भने यो लेभल गरिन्छ. तर at times we may not know when patient आउँछ 7 months मा 28 weeks मा blood pressure high छ भने whether to label it as a hypertension or not भन्ने कुरा चाहिँ maybe about delivery भएको 12 weeks postpartum सम्म subside भयो भने hypertensive disorder in pregnancy भन्छौं. So incidence is around 3.7% of all pregnancies and 16% of pregnancy related deaths occurs because of hypertensive disorder of pregnancy. So there is a specific classification of hypertensive disorder in pregnancy. So according to National High Blood Pressure Education Program, it has been divided into 5 classes: gestational hypertension, preeclampsia, eclampsia, preeclampsia superimposed on chronic hypertension, and the final class is chronic hypertension only. So we have 5 classes, that is gestational hypertension, preeclampsia, eclampsia, preeclampsia superimposed on chronic hypertension, and final class is chronic hypertension. So gestational hypertension is 140/90 blood pressure after 20 weeks of gestation, which is not associated with proteinuria. There should not be proteinuria. That will be labeled as gestational hypertension. When preeclampsia is there, there should be proteinuria. Hypertension plus proteinuria means preeclampsia. Preeclampsia is again divided into mild preeclampsia and severe preeclampsia. Mild is 140/90 millimeter of mercury with 1 plus proteinuria, whereas in case of severe preeclampsia, blood pressure is systolic 160 and diastolic is 110 or more, and proteinuria, which is 5 gram per 24 hours or more. There may be deranged creatinine, there may be low platelet count, there will be evidence of microangiopathic hemolysis, there will be elevated and patient will be symptomatic. The 3 symptoms of hypertension pregnancy is headache, blurring of vision, and epigastric pain. So whenever patient comes with a high blood pressure during pregnancy, we have to ask about these 3 symptoms: whether she is having headache, whether she is complaining of disturbed vision, or epigastric pain is present or not. If these symptoms are present, then the maternal and fetal outcome may be serious. Eclampsia is it's a seizures in pregnancy where mother is hypertensive. That means hypertension with or without proteinuria, but patient with presence with tonic-clonic seizures is eclampsia. Superimposed preeclampsia means there is a new onset proteinuria in a chronic hypertensive woman. Like say a 35 years lady with a blood pressure of 160/100 or 150/100, who was not non-proteinuric, or she doesn't have proteinuria previously. Whenever she presents with proteinuria during pregnancy, that is superimposed preeclampsia. Like patient is already hypertensive, there is a new onset proteinuria. Or another condition is there may be worsening proteinuria in case of previously proteinuric hypertensive patient is superimposed. Chronic hypertension is a normally a lady may be hypertensive, she can become a pregnant, that is chronic hypertension. So there are few conditions that has to be kept in mind to label a patient as a case of severity or severe disorders of hypertensive disorders. Like diastolic blood pressure should be more than 110 millimeter of mercury. There may be marked proteinuria. Patient will have symptoms of headache, blurring of vision, and epigastric pain. Patient can at times present with oliguria, and sometimes there may be convulsions. There may be deranged lab tests like there may be elevated serum creatinine, thrombocytopenia, liver enzymes may be deranged. There may be evidence of fetal growth restriction and pulmonary edema. सुनिरहेछ है?
Yes, sir.
So gestational hypertension, I've already said it is not associated with proteinuria. Blood pressure is 140/90 or more. Preeclampsia, there is a proteinuria along with hypertensive changes. And superimposed preeclampsia, again, there is a proteinuria, new onset proteinuria in chronic hypertensive patient. So we have few medical causes of underlying chronic hypertension, like essential familial hypertension is the commonest one. Others are obesity, arterial abnormalities, endocrine disorders, glomerulonephritis, renal peripheral hypertension, connective tissue disease, polycystic kidney disease, or acute kidney injuries. So lots of researches has been made till date, but exactly what is the cause of a lady who will develop hypertension in pregnancy is not known. But still, there are certain postulated theories like nulliparity, advanced maternal age, and certain race and ethnicity, multifetal gestation, obesities with a BMI more than 35 kg per meter square are the risk factors for hypertension in pregnancy. So, why exactly hypertension occurs? It is entirely related to the chorionic villus. That means those ladies who are exposed to chorionic villi for the first time, or those who had a superabundance of chorionic villi, as in case of twins and molar pregnancy, are prone to have a hypertensive disorder, or a lady who has a pre-existing vascular disease, and at times certain genetic predisposition has been postulated. So what happens in hypertensive disorder in pregnancies? There will be abnormal trophoblastic invasions, and there will be that could be immunologically intolerant between the maternal and fetal tissues, or maternal maladaptation to certain inflammatory changes, or some researchers has thought about dietary deficiencies and genetic influences comes for all the diseases. So this is the normal implantation. In a non-pregnant patient, you can see in the picture that the spiral arteries are of normal diameter. And in case of normal pregnancy, what happens there is there will be a marked invasion of the spiral arterioles by the trophoblast, so that there is you can see the vessels are markedly dilated. But when we evaluate the case of preeclampsia, this trophoblastic invasion to the spiral arteriole will be reduced. You can see the picture clearly. So this is the reason why patient will develop hypertensions. Other conditions are endothelial damage, inundation of plasma constituent into the vessel wall, proliferation of myointimal cells, medial necrosis. This has been researched in many places. So you don't need all these things, but just remember, pregnancy with hypertension is a disease because of the abnormal trophoblast or placenta itself. So what happens here in case of it's a vicious process. Okay, so whenever there is abnormal trophoblastic invasion because of any reason, it could be faulty placentation, it could be excessive trophoblastic invasion, or it could be genetic factors or maternal vascular disease, there will be a reduced uteroplacental perfusion. This will lead to vasoactive agents activations like prostaglandin, nitric oxides, and endothelins. Lipid peroxidase, and there will be endothelial cell activations that will lead to vasospasm. Capillary will become leaky, and there will be a activation of coagulation systems. And whenever there is vasospasm, it will lead to hypertension, seizures, oliguria, abruption, and liver ischemia. In case of endothelial cell activations, it can lead to capillary leaky, which will lead to edema, proteinuria, and hemoconcentration. That's why during antenatal checkup, we used to look for blood pressures and dependent site edema. And whenever there is activation of coagulation system, that will lead to thrombocytopenia. And this is how the disease process advances during pregnancy. So this hypertensive disorder affects all the system. In cardiovascular system, there will be increased afterload, there will be a diminished preload, and the endothelial cell activation and extravasation occurs, and there will be a decreased cardiac output, hemoconcentration from generalized vasoconstriction and endothelial cell dysfunctions, and there will be a decreased blood volume. In a blood coagulation system, it can cause thrombocytopenia. It activates the intrinsic coagulation systems that will be leading to clotting factor deficiencies and ultimately DICs. And there will be activations of all these vasoactive amines, and that will lead to this decrease in urine output, and at times there will be endothelial cell injuries, which causes leakage of protein into the interstitial spaces, and there will be a low urine output as well as there will be a low intracellular volume, intravascular volume. There will be a this glomerular filtration rate and renal plasma flow all will be reduced, and that will lead to elevated uric acid. So whenever we are evaluating a case of hypertensive disorder in pregnancy, uric acid is the first biochemical marker that will be changed. And when we don't detect during this phase, and ultimately there will be a elevation of creatinine and urea will occur, and that can lead to renal failure at times. Proteinuria, we can easily diagnose by just a dipstick test, and whenever you see proteinuria in dipstick test, you have to evaluate with 24 hours urine protein. Sunira sir?
Yes, sir.
बेला बेलामा इन्टरनेट स्लो भनिरहेछ है, सुनेन भने भन है. And in liver, it causes periportal hemorrhage, and there will be elevated liver enzymes, and that will lead to HELLP syndrome. HELLP syndrome is nothing; it's a hemolysis, elevated liver enzyme, and low platelet count. H stands for hemolysis, EL stands for elevated liver enzymes, and LP stands for low platelet count. It's a severe form of hypertensive disorder of pregnancy. So patient can have HELLP syndrome, which has a mortality as high as 40-50% whenever patient will develop HELLP syndrome. And the vasogenic edema or cerebral vasoconstriction can cause certain symptoms, which includes headache and blurring of vision. And epigastric pain is because of periportal hemorrhage that occurs in liver. So whenever you think she is having a severe preeclampsia, at times we need to do a neuroimaging with CT scan, and sometimes with magnetic resonance imaging is needed. So blindness is at times very common in case of uncontrolled hypertension during pregnancy, but the good part of this is usually it resolves within a week. So if patient develops widespread vasogenic edema, patient will have a lethargy, patient may be confused, she will have a blurred vision, and many times we encounter patient in coma, and the treatment will be mannitol and steroids, dexamethasone. Uteroplacental perfusion is very important part when we are dealing with hypertensive disorder in pregnancy. There will be a compromised uteroplacental perfusion from the vasospasm, and there will be a mean diameter of the myometrial spiral arterioles will be decreased, and this will be evaluated with doppler flow velocimetry of uterine artery. So during hypertensive disorder in pregnancy, there will be intrauterine growth restrictions. The initial features that we see is there will be flow velocity in uterine artery will be diminished. This will be evaluated with Doppler, ultrasound Doppler. So lots of researches were being made earlier, whether we can predict which lady will develop hypertension during pregnancy, which lady will not develop by doing certain tests. So lots of things has been evaluated. That could be biological markers, that could be biochemical markers, or some biophysical markers. But exactly, we don't know who will develop hypertension during pregnancy. So these all markers were evaluated to see the faulty placentations. There will be a reduced placental perfusion भन्ने जुन theory थियो त्यसलाई evaluate गर्नलाई endothelial cell activation and dysfunction को theory छ र activation of coagulation system हेर्नलाई हामीले different markers हरु use गर्यौं. Just remember the test. Rollover test is one test that is being done at 28 to 32 weeks. जसले चाहिँ पछि गएर हाइपरटेन्सन हुन्छ कि हुन्न भन्ने प्रेडिक्ट गर्छ भनेर देखाएको थियो. तर later on it was found it was not found helpful. Uric acid अघि मैले भने first marker to be changed. So whenever patient को early pregnancy मा हामीले uric acid हेरेर त्यहाँ certain changes छ भने पनि हामीले प्रेडिक्ट गर्न सक्छौं कि भन्ने evaluation पनि भयो, but it is also of no use. Fetal fibronectin is the newer thing that has been evaluated nowadays. सुरुमा चाहिँ यसको पोजिटिभ प्रेडिक्टिभ भ्यालु एकदम राम्रो छ हैन. हामीले E5 fetal fibronectin maternal serum मा हेर्न सक्यौ भने चाहिँ त्यसले चाहिँ यो पेशेन्टमा हाइपरटेन्सन डेभलप गर्छ भनेर प्रेडिक्ट गर्न सक्छौं भन्ने कुरा आयो. तर दिस वाज अल्सो नट हेल्प. कोआगुलेसन डिस्फंक्सन हुन्छ, we know during pregnancy. So lots of coagulation markers has been evaluated, but it's also of no use. Certain cytokines were evaluated like interleukin, human necrosis factor alpha, and CRP as inflammatory response, but यसको पनि prediction मा केही काम छैन. Placental peptides were evaluated, no role. Fetal DNA was seen in maternal serum, अनि त्यसले पनि प्रेडिक्ट गर्न सकिन्छ भन्ने कुरा आयो. तर it has also no major role. The only role is uterine artery doppler. So if you do uterine artery doppler, who has a high risk, अघि जस्तो भने genetic predisposition हुन सक्छ हैन, मदर एन्ड फादर बोथ हाइपरटेन्सिभ छ भने यस्तोमा चाहिँ हामीले जेनेटिक प्रिडिस्पोजिसन हुन्छ भनेर भन्दाखेरि यो युट्राइन आर्टरी डपलर चाहिँ हामीले अर्ली प्रेग्नेन्सीमा 8 to 22 weeks मा गर्दाखेरि सुनिराछ.
Yes, sir.
Yes, sir.
ओके, युट्राइन आर्टरी डपलर पनि इभ्यालुएट गर्नलाई एउटा मिन्स हो जसले गर्दाखेरि फिटल आउटकम अथवा म्याटरनल हाइपरटेन्सन चाहिँ अर्ली डिटेक्ट गर्न सकिन्छ कि भन्ने एउटा प्रेडिक्सन छ. HCG or human chorionic gonadotropin hormones is being evaluated. जस्तै हाइपरप्लासेन्टेसन भयो अथवा एब्नर्मल प्लासेन्टेसन भयो हुँदाखेरि चाहिँ HCG लेभल हाई हुन्छ भनेर पनि एउटा थ्योरी आयो. सो whatever investigation we did to predict, यिनीहरुको खासै रोल चाहिँ छैन. सो what next त अब सबै टेस्ट गर्दाखेरि छैन भने चाहिँ can we prevent or predict गर्न सकेन, can we prevent the disorder भनेर हामीले अरु प्रेग्नेन्सीको अरु नन प्रेग्नेन्टमा हाइपरटेन्सन हुँदाखेरि चाहिँ ल यस्तो पेशेन्टमा चाहिँ अलिकति वेट रिडक्सन गरौँ हैन, त्यसपछि साल्ट रेस्ट्रिक्सन गर्छौं हैन, एक्सरसाइज गराउँछौं, डायuretic थेरापीहरु युज गर्छौं. अनि यो गर्दाखेरि फाइदा हुन्छ कि भनेर हेर्दाखेरि पनि साल्ट रेस्ट्रिक्सन वाज फाउन्ड टु बी इनइफेक्टिभ. डायuretic थेरापी दिने नै हुँदैन हाइपरटेन्सिभ डिसअर्डर इन प्रेग्नेन्सी. दो non pregnant population ma diuretics are the first line of antihypertensive that is being used. तर pregnancy induced hypertension मा चाहिँ प्रब्लम के हुन्छ त भन्दाखेरि जुन चेन्जेस आउँछ त्यसमा जहिले पनि डिमिनिस्ड इन्ट्राभास्कुलर भोल्युम हुन्छ. सो डिप्लिटेड इन्ट्राभास्कुलर भोल्युममा अझ हामीले डायरेटिक दिएर फ्लुइड वास आउट गर्यो भने that will have a more detrimental effect. That's why diuretic therapy is not indicated. At times कहिलेकाहीँ चाहिँ पेशेन्ट पोस्टपार्टम मा अथवा डेलिभरी भएपछि पनि हाइपरटेन्सन सेटल भएन, एकदम सिभियर ओलिगुरिया भइराछ भने चाहिँ we do give diuretics to preserve the kidney, but antenatally चाहिँ diuretic therapy should not be used. अनि अर्को चाहिँ क्याल्सियम डेफिसिएन्सी ले गर्दाखेरि चाहिँ हाइपरटेन्सन हुन्छ भनेर एउटा ठुलो ट्रायल भयो. सो जुन पनि पेशेन्टहरुमा चाहिँ क्याल्सियम हामीले हाई डोजमा युज गर्यौं भने चाहिँ हाइपरटेन्सन प्रेग्नेन्टमा प्रिभेन्ट हुन्छ भनेर एउटा रिसर्चले देखाएको थियो. बट इन अ लङ टर्म स्टडी त्यसमा पनि क्याल्सियमको पनि युज खास छैन. हामीले प्रेग्नेन्सीमा युज गर्ने क्याल्सियम चाहिँ इट्स नट फर प्रिभेन्सन अफ प्रिएक्लाम्सिया, रादर इट्स फर फिटल बोन डेभलपमेन्ट हो हैन. अरु जस्तै एन्टिअक्सिडेन्ट्सहरू लाइक फिस ओइल क्याप्सुल्सहरू युज गरेर फाइदा हुन्छ कि भन्दा हेऱ्यौँ त्यो पनि त्यति इफेक्टिभ छैन। लो डोज एस्पिरिनको चाहिँ एउटा ठुलो ट्रायल भयो, त्यो ट्रायलले चाहिँ लो डोज एस्पिरिन चाहिँ युज गर्नु भनेर भन्छ। त्यसको चाहिँ अब कोआगुलेसन डिसअर्डर जुन गर्छ त्यो पार्टलाई चाहिँ हामीले करेक्सन गर्न सक्छौँ भन्ने हिसाबले हो। स्टिल नाउ डेज अल्सो वी आर युजिङ लो डोज एस्पिरिन फर ट्रिटमेन्ट अफ अर प्रिभेन्सन अफ preeclampsia तर एस्पिरिन युज गरिरहेछौँ भने चाहिँ whenever you are thinking that delivery is imminent or we need to deliver in a few days, you have to stop aspirin because it blocks the platelet. That's why you have to stop routinely and aspirin use गरिरहेछौँ भने चाहिँ at around 35-36 weeks we need to stop aspirin because maybe in a week or two we are going to deliver that patient with cesarean section or even in normal delivery she can have a profound amount of blood loss. Antiplatelet पनि युज गरे कति रिसर्चरले त्यसको फाइदा पनि छैन। Vitamin E supplementation has no such evidenced role during prevention of preeclampsia. Vitamin C or the antioxidants has no role and folic acid supplementation को पनि मान्छेहरूले स्टडी गरे त्यसको पनि खास रोल त छैन तर हामीले फोलिक एसिड सप्लिमेन्टेसनबाट चाहिँ एब्नर्मल प्रेग्नेन्सीहरू हुने लाइक न्युरल ट्युब डिफेक्ट्सहरू चाहिँ प्रिभेन्ट गर्न सक्छौँ। सो म्यानेजमेन्ट मैले जहिले पनि भन्छु हैन, हाइपरटेन्सिभ डिसअर्डर इन प्रेग्नेन्सी इज भेरी कमन इन प्रेग्नेन्सी एन्ड इट इज भेरी इजी टु डायग्नोज हैन, very easy to diagnose. Even you can diagnose hypertensive disorder in pregnancy because you know the definition. After 20 weeks of gestation, if a lady had a blood pressure of 140 or 90 millimeter of mercury in a previously normotensive woman, then that is hypertensive disorder in pregnancy. It's really easy to diagnose. If she has a proteinuria, that is preeclampsia. But management, it's really difficult. तिमीलाई मैले जहिले पनि म्यानेजमेन्टको इश्यूज आउन साथै जहिले पनि के भन्छु त, it depends on gestational age. Gestational एजमा डिपेन्ड गर्छ डिजिजको सिभिरिटी र अर्को कुरा चाहिँ म्याटर्नल कन्डिसन्स हैन। इफ मदर इज डुइङ वेल वी टेन्ड टु कन्टिन्यू प्रेग्नेन्सी टिल टर्म, तर मदर डिटोरिएट गरिरहेछ भने एट टाइम्स वी निड टु sacrifice the fetus as well. त्यो भएर दुई तीनवटा इस्यु के भयो त, एउटा चाहिँ हाइपरटेन्सनले मदरमा कति चेन्जेस ल्याएको छ। सी सिम्पटोमेटिक छ, हेडेक, ब्लरिङ अफ भिजन, एपिगास्ट्रिक पेन कम्प्लेन गरिरहेछ, इरेस्पेक्टिभ अफ जेस्टेसन एज वी निड टु टर्मिनेट द प्रेग्नेन्सी हैन। सो एन्ड termination of pregnancy is the only treatment for hypertension during pregnancy, but we need to continue the pregnancy if mother is doing well and good. If there is no significant changes in our body because of hypertension, then we need to continue the pregnancy. That's why antenatal care is important. Antenatal visit ma हामीले early pregnancy मा monthly visit गराउँछौं, त्यसपछि second trimester बाट हामी अलि फ्रिक्वेन्टली भिजिट गराउँछौं र पहिला यदि मदरको चाहिँ हाइपरटेन्सन छ भने चाहिँ अझ मोर फ्रिक्वेन्टली हामीले भिजिट गराउनु पर्यो हैन। सो हामीले एन्टिनेटलमा वन्स ब्लड प्रेसर इज 81 to 89 छ डायस्टोलिक ब्लड प्रेसर, अनि त्यसमा चाहिँ हाम्रो अलिकति भिजिलेन्ट मोनिटरिङ हुनु पर्यो। अनि ब्लड प्रेसर अब 90 भन्दा बढ्न थाल्यो, पेशेन्ट सिम्पटोमेटिक छैन भने नियर बाई बस्छ भने पनि ओपीडी भिजिटमा ओपीडी बेसिसमा हामीले ट्रिटमेन्ट गर्न सक्छौं। पेशेन्टलाई नियर बाई कहीं अब हेल्थ सेन्टर्सहरु छन् त्यहाँ ब्लड प्रेसर मोनिटर गर्ने, डायस्टोलिक 100 भन्दा बढी भयो भने हस्पिटल आउनु भनेर, र सिस्टोलिक मोर देन 140 भयो, ग्रस लेग स्वेलिङहरु भयो भने आउनु भनेर भन्छौं। अब हाम्रो भिजिटमै 160/110 छ, 3+ प्रोटिनुरिया छ भने यु नीड टु एडमिट द पेशेन्ट, use antihypertensive and think about baby. If baby is premature, we have to give steroids. And proteinuria deteriorate भइराछ, मर्निङमा एडमिट गर्यो 2+ प्रोटिन थियो, इभिनिङमा 3+ प्रोटिन भयो भने we need to terminate. Or if patient is symptomatic like headache, blurring of vision and epigastric pain छ भने we have to think about terminating the pregnancy. So even at around maybe 34-35 weeks of pregnancy, we have to evaluate the fetal conditions. हाम्रो aim or tendency के हुन्छ त 37 weeks cross गरौँ भन्ने हुन्छ, तर if fetus is compromised inside the uterus, that means there is intrauterine growth restriction छ भने give steroid and plan for delivery. Delivery is the cure for preeclampsia, headache, visual disturbances, or epigastric pain are indicative of convulsion. त्यो भएर कुनै पनि hypertensive woman who is complaining of headache, blurring of vision, and epigastric pain छ भने be serious about that patient. In an hour or two, patient can throw fits. That's why you have to be very much careful about these patients. Oliguria is an ominous sign. हैन अब त renal impairment सुरु भइसकेपछि त झन् vicious cycle जान्छ. त्यस्तो कन्डिसनमा चाहिँ हामीले सोच्नुपर्ने के त हाइपरटेन्सिभ पेशेन्टलाई हामीले एडमिट गरेछ भने you have to monitor the urine output. That could be self-voided urine output, or you can catheterize the patient for strict output monitoring hourly. So termination of pregnancy, which mode? भन्दाखेरि obstetric indication छ भने cesarean section हो. Other than that, you can always give trial of labor. You can induce with oxytocin, or if at times you need pre-induction cervical tightening with prostaglandins. Induction of labor is not harmful to infants, but many a time it is unsuccessful. Antihypertensive drug is not the treatment of hypertensive disorder in pregnancy. It is only the thing that we can control the blood pressure so that we can modify the perinatal outcomes, or we can continue a pregnancy for few more days. So antihypertensive के use गर्ने त भन्दाखेरि हामी चाहिँ OBGYN ले commonly use गर्ने भनेको calcium channel blocker. हाम्रो nifedipine available छ जुन चाहिँ plain and retard formulation मा आउँछ. Plain मा you can use 4 hourly up to 4 hourly हैन. हामीले normally start गर्दा 8 hourly start गर्छौं. 10 mg 8 hourly orally. अनि कहिलेकाहीँ just 32 weeks छ अथवा 30 weeks छ त्यस्तो पेशेन्टमा हाइपरटेन्सन भयो भने चाहिँ हामीले prolonged period सम्म हाइपरटेन्सन एन्टिहाइपरटेन्सिभ कन्टिन्यू गर्नु छ भने चाहिँ मिथाइल डोपा युज गर्छौं. मिथाइल डोपा अन एन्ड अफ कहिले अवेलेबल हुन्छ कहिले हुँदैन. You can start with 250 mg TDS, and if blood pressure is not controlled, you can increase the dose out to 500 mg 3 times a day. अनि कहिलेसम्म कन्टिन्यू गर्ने त मिथाइल डोपा until delivery. Delivery पछि चाहिँ मिथाइल डोपा is not safe in postpartum mother because it can cause psychosis. कहिलेकाहीँ हामीलाई यो ओरल मेडिकेसन्सहरुले हाइपरटेन्सन कन्ट्रोल गर्न गाह्रो हुन्छ. त्यस्तो बेलामा चाहिँ अवेलेबल intravenous antihypertensives that we commonly use are hydralazine and labetalol. So ACE inhibitors should not be used in pregnancy because it can cause oligohydramnios, intrauterine growth restriction, bony malformation in baby, limb contractions, persistent pattern doctor's arteries गर्न सक्छ, pulmonary hyperplasia गर्न सक्छ, respiratory distress syndrome गर्न सक्छ, prolonged neonatal hypertension and neonatal death गर्न सक्छ. Early pregnancy मा ACE inhibitors लिइराछ भने that has to be discontinued as soon as it is detected. कहिलेकाहीँ हामीले प्रेग्नेन्सी कन्टिन्यू गर्ने कि नगर्ने भनेर हामी डाइलेमामा हुन्छौं. त्यस्तो अवस्थामा चाहिँ हामीले जहिले पनि वे गर्नु पर्यो which one is beneficial for both mother and baby. Steroids are not contraindicated. हैन अब स्टेरोइड दियो भने प्रेसर एन्टिहाइपरटेन्सिभले काम गर्दैन अथवा हाइपरटेन्सिभ डिसअर्डर चाहिँ डिटेरियोरेट हुन्छ भन्ने जुन उस छ त्यो चाहिँ किनभने सर्ट टर्म युज गर्ने भएको भएर इट डजन्ट कज एनी प्रब्लम. पहिला पहिला हेल्प सिन्ड्रोममा स्टेरोइड्स रुटिनली युज गर्थ्यो, तर अहिले चाहिँ नयाँ एभिडेन्सले चाहिँ के हेल्प गर्दैन भन्छौं. तर समथिङ इज बेटर देन नथिङ भनेर स्टिल हेल्प सिन्ड्रोममा पनि हामी युज गरिरहेका हुन्छौं. बट गुड थिङ इज इट क्यान इन्क्रिज द ल्याब डिस्फङ्सन्सहरु देखिएको छ भने एउटा ट्रान्जिएन्टली त्यसले त्यो पार्ट चाहिँ इम्प्रुभ गर्छ कि भन्ने देखिएको छ. सो दिस इज अल अबाउट हाइपरटेन्सिभ डिसअर्डर इन प्रेग्नेन्सी. के क्वेशन छ? के क्वेरीज क्वेशन्स? सुनिरहेछ?
Yes, sir.
Now, we'll stop it here today. है नेक्स्ट क्लासमा इक्लाम्सियाको क्लास लिन्छु. अब त्यो अनलाइन क्लास भन्दा पनि अब बेटर चाहिँ फिजिकली लिँदाखेरि हुन्थ्यो किनभने इट्स अ भेरी इम्पोर्टेन्ट टपिक इक्लाम्सिया. त्यसमा मैले डेमोन्स्ट्रेट पनि गरेर देखाउनु पर्ने हुन्छ कति कुराहरू. सन्डे छ, मोस्ट प्रोबेबली सन्डेबाट फिजिकल हुन्छ कि भन्ने होप गरेको छु है. फिजिकल भएन भने पनि अनलाइनमा कसरी पोसिबल हुन्छ डेमोन्स्ट्रेट गरेर देखाउनलाई त्यो चाहिँ आई विल ट्राई. ठीक छ?
Yes, sir.
सुनिरहेछ?
Yes, sir.
हजुर सर.
Thank you, sir. Thank you for attending the class. See you in next class.
Thank
Thank
you,
you,
sir.
sir.
Bye.
Have a nice day.